Greetings from Indian Journal of Anaesthesia. I, Dr. Reniki Sharma, will be presenting an article published in the October 2024 issue of Indian Journal of Anaesthesia. It is titled Comparing the Effects of Three Local Anesthetic Agents on Cardiac Conduction System, a randomized study. Cardiotoxicity is a major concern with local anesthetic agents, especially when used in high doses or for extended periods. Epidural anesthesia provides optimal surgical conditions and prolonged postoperative pain relief, but requires larger local anesthetic volumes, increasing the risk of toxicity. The R plus isomer of bupivacaine has a high affinity for sodium channels, leading to greater toxicity, whereas the S plus enantiomer, levobupivacaine, has reduced CNS and cardiac toxicity. Ropivacaine and S enantiomer of ropivacaine has similar properties to bupivacaine but with lower systemic toxicity. So this study aimed to compare bupivacaine, levobupivacaine, and ropivacaine in terms of their effects on cardiac conduction during epidural anesthesia and also assess the onset and quality of analgesia provided by these agents in lower limb surgeries. The primary objective was to compare the effect of the three local anesthetic agents on cardiac conduction in surgeries under epidural anesthesia. The secondary objective was to find out the effect of these local anesthetic agents on the onset and quality of analgesia in patients undergoing lower limb surgeries. So Institutional Ethical Committee approval was taken and the trial was registered in Clinical Trial Registry of India. It was a randomized controlled trial with adults 18 to 65 years of age, ASA grade 1 to 2, undergoing elective lower limb surgery under epidural anesthesia and postoperative analgesia through a patient-controlled analgesia pump. Patients with hypersensitivity to amide local anesthetics on antiarrhythmics on drugs causing alteration to cardiac conduction system were excluded from the study. Pregnant patients were excluded from the study. Patients with hypovolemia, hemorrhagic shock, with raised intracranial pressure, with anemia, coagulopathy, or infection were excluded from the study. Patients with neurological, cardiovascular, renal, hepatic, respiratory diseases, or congenital spinal anomalies or vertebral injuries were excluded from the study. An anesthesiologist, not part of the study, selected the local anesthetic agent by drawing lots into three groups. Group B received 0.05% bupivacaine, Group L received 0.5% levobupivacaine, and Group R received 0.75% ropivacaine. Data was collected by a blinded anesthesia resident, and preoperatively, all patients were explained regarding the patient-controlled analgesia pump and the visual analog sport for pain. Holter monitoring was started 30 minutes before the surgery in the preoperative room and the recording was started. It was continued till 24 hours of postoperative period. So in the OT, ASA standard monitors were attached and the baseline vitals were measured. An interlaminar space between L1 and L4 was identified, infiltrated with local anesthetic with ADR, and an 18-gauge epidural needle was inserted and the space was confirmed by loss of resistance to saline, after which a 20-gauge epidural catheter was threaded through the needle till 5 centimeter was cathetered in the epidural space. A test dose was given and patients were turned supine if no motor block or tachycardia was there. Surgical anesthesia was instituted with group-specific 15 ml of local anesthetic. If the desired block was not achieved, then 4 ml of increments of local anesthetic was given after 15 minutes. So the onset of sensory block was checked at 1 minute interval by pinprick sensation to a 27 gauge needle, and the absence of pinprick pain at T10 level was the onset time of sensory block. The end of bolus injection of the study drug was considered as time 0 for patient assessment. So all vitals were measured at baseline at 0 minute, 5 and 10 minutes, and then a 10-minute intervals for 1 hour, and then half an hour interval till completion of surgery. Postoperatively at 2 hours, 4, 8, 12, 16, 20, and 24 hours after the epidural bolus. And the patient control analgesia pump was started 2 hours after the epidural bolus. All patients received paracetamol 8 hourly 1 gram, and if still VAS was more than 7, then 75 milligram diclofenac IM was given. So postoperatively for PCI infusion, In group B, 0.0125% bupivacaine was used. In group L, 0.0125% levobupivacaine was used. And in group R, 0.2% ropivacaine was used. For PCA pump, the basal infusion was 4 ml per hour with a demand dose of 4 ml and a lockout interval of 15 minutes with maximum dose of 3 per hour. So the primary outcome was the corrected QT interval and the P-wave dispersion at baseline, various time points intraoperatively and postoperatively. The secondary outcome was time to onset of sensory block, time to onset of motor block, the patient control analysis at demand dose and total dose, and the pain scores at time points 2, 4, 6, 8, 12, 16, and 24 hours postoperatively. A sample size of convenience of 25 per group was taken and a p-value less than 0.05 was considered significant. So this is the consort diagram and this is the table showing the baseline demographics between the three groups, which is similar. So the primary outcome, the mean corrected QTC and the p-wave dispersion. So if we can see in all the three groups from the baseline at all time points, the QTC and the pulse wave dispersion increases, but the maximum increase is seen with group B, that is bupivacaine group, and that is statistically significant. Even in the post-operative period, the QTC increases across all time points in all the three groups. For the secondary outcomes, that is the onset of sensory block at T10, onset of motor block, demand dose of PCA and total dose of PCA. These are similar set between the three groups and statistically not significant. For the VAS scores among the three groups at various time points postoperatively, the VAS scores are low and statistically not significant. So the QTC and the pulse wave dispersion significantly increased from baseline across all groups, with group B showing a higher mean increase compared to group L and R. All three local anesthetic had similar effects on hemodynamic, sensory, and motor block at onset and post-operative analgesia quality. The QTC interval was comparable between bupivacaine and levobupivacaine initially, but discrepancies in results may be due to difference in dosing between studies. There is no significant difference in QTC or pulse wave dispersion observed between bupivacaine and levobupivacaine in previous studies, though ropivacaine showed a significantly different analgesic profile. The study's strength include comparing three agents over 24 hours for cardiac conduction changes, but limitations involve the lack of correlation with serum concentrations and being a single-center study. So to conclude, bupivacaine shows the greatest tendency to prolong the cardiac conduction as indicated by the corrected QT interval and P-wave dispersion compared to levobupivacaine and ropivacaine when administered via the epidural route over a 24-hour period. Thank you.